Thank you very much indeed to everybody for inviting me. And yes, I'm lucky enough to be Chief Executive of SANS, but also lucky enough to be co-chair of the Smoking in Pregnancy Challenge Group. And the slides I'm showing you put together also with the help from Ash, who do an enormous amount for the Smoking in Pregnancy Challenge Group. And what I want to do is share with you the impact. It says on mothers and babies, but actually, as we all know, it's families, it's whole families and babies, not just the mothers. Next slide, please. So what I want to do is just have a look at the overview of smoking and perinatal mortality and its impact, but also, again, Ruth's mentioned the 6% ambition, but just kind of putting that in that picture. Not touching on national initiatives because Ruth has done that very effectively, but perhaps looking more detail at smoking in high prevalence communities and then what the financial cost is. Thank you. Next slide. But before we start, I just want to spend a moment focusing on what the real cost is every day to these families whose babies die. I miss my baby every second of every day, and even though the pain will ease and the hurt will fade, I will always, for the rest of my life, not have my baby. And I think all of us in this meeting know that for these parents, it isn't just an event that happens at the birth. This is a journey that they're on for the rest of their lives. And this is a journey that sometimes can be prevented, or the risk factors can be addressed. And I think it's about understanding what can we do to reduce the risk and to help these families not have to go through these terrible, terrible losses. At SANS, obviously supporting parents every day, families every day, particularly through the lockdown, through the pandemic. Demand for our services have increased by about a third, but it's the thing that is heartbreaking is the number of parents who A, say they didn't know that this could happen in this country, but B, sometimes say, if only somebody had told me that if I had given up smoking, if I had done such and such, I might have reduced my risk. And I think that to me is really, really sad. And one of the things that, again, the conversations that we have are, especially with younger mothers, that they understand that they should give up smoking, but they don't understand why. And time and again, we hear, I didn't know that my baby might die. And I think that's something that we really need to work with and help these parents understand, identify those parents who need that conversation and to understand the effect of smoking. Thank you. Next slide. So the overview, the first click through, as I've said, it's responsible for an increased rate of stillbirths, miscarriages and birth defects. There's also a major health inequality, and these two things I want to look at in a little bit more detail. The women from more deprived backgrounds are more likely to smoke during pregnancy and be exposed to secondhand smoke, and this in itself is so unfair, is something we absolutely should be tackling. We shouldn't have these sorts of inequalities. And apart from the risks, the perinatal mortality and the birth defects, obviously there are other risks as well. So respiratory conditions, attention, hyperactivity difficulties, the whole range of ear, nose and throat, obesity and diabetes. There are so many reasons that we should be helping these mothers understand the risks and then helping the mothers to take the steps if that's what they would like to do in order to stop smoking. Next slide, thank you. So the scale of perinatal mortality is around 5,000 babies dying, and this isn't miscarriage, this is stillbirth and neonatal death every year. And that, if you round it up, and we click on the next one, shows it's about 14 babies dying every day. 14 families today will be affected by perinatal mortality, and we do need to do something about this. Next slide. As Ruth has already said, the national ambition to halve stillbirths and neonatal deaths by 2025 is something that I know that you will all be focused on, that we're all focused on. And all of those actions, those safety initiatives that are helping reduce the number of stillbirths are making progress, but during the pandemic, so many of those initiatives, as we all know, have had to take second place for a little bit, and that worry about getting back on track and actually back on that path to achieving those figures of 50% reduction, particularly worrying perhaps for neonatal deaths, which have absolutely flatlined. And I think trying to understand why and what needs to happen is a whole other question. Next slide, please. So the main modifiable risk factors, and if we click once more, I've highlighted in a circle here those top 4. So smoking is the single biggest modifiable risk factor for perinatal mortality. Those top 4 are things that parents, mothers can do for themselves. The smoking, the obesity, obviously the position that they sleep in, and telling somebody if their baby's movements change. And I think, again, time and again, we hear parents saying, if I had understood, I could have made that decision. And if we click once more, there is a quote here from a mother saying, the thing that really hit home for me was when the midwife at hospital showed me how much carbon monoxide was in my breath and explained how smoking starves the baby of oxygen. So we need the buy-in from mothers to help reduce those stillbirth and neonatal rates. But until those mothers understand and can feel motivated, that we're not even on that journey. And the carbon monoxide monitoring obviously enables midwives to identify those mothers who need to have that conversation. Thank you. Next slide. So the figures are very, very stark. Obviously, the smoking is particularly has particular impact, but so does secondhand smoke. And if we look down, stillbirth nearly 50% more likely if the mother is smoking. Miscarriage nearly well over 30%, 32% more likely, and SIDS 3 times more likely. The risk of these babies dying, it's heartbreaking, and obviously the problems that go with preterm and low birth weight. Again, this is a journey that the parents are then on for a very, very long time. Thank you. So as Ruth has said, the 6% ambition, that's the tobacco control plan for England. So by next year, reducing to 6%, which is a real challenge, and we are not on track for that at all. So the challenge group estimated that if we did achieve 6% across England by 2022, you can see how many babies' lives would be saved, but also an enormous number of babies, both preterm and low birth weight, who'd have their outcomes affected as well. And this is just by, I'd say just, and I know what a challenge it is, but addressing smoking, identifying those mothers who need that conversation to understand the impact and then be supported to make those changes in their behaviour. And I know that in this region, you've got an ambitious target of reducing to 5% by 2025. So again, there's a kind of an added layer here, adding into that. So just thinking about this high prevalence communities, we know that women from disadvantaged backgrounds are more likely to smoke and more likely to relapse afterwards if they do manage to quit. We also know that women in the most deprived decile are over 5 times more likely to smoke. And the higher rates of smoking among younger and more deprived women do correspond with the higher rates of infant mortality. So it's directly related here. And the other significant thing is that the booking rates are highest among the white and the mixed ethnic groups. And those white groups include Eastern European countries who might not be sufficiently engaged by the current stop smoking interventions. So we know the groups that perhaps need support and help. And I've got a few graphs which show this, I think, quite clearly. So in the next one, really clearly you can see in the most deprived group, nearly 1 in 4 are smoking, whereas right down at the least deprived group, it's under 5%. That is a stark inequality that needs to be addressed. And then the next, this also shows really, really clearly the effect of age. So in the 18 to 19 age group, over 30%, and then obviously dropping right down once mothers are in their kind of late 20s and 30s. And then ethnicity again shows the white and the mixed groups being much more likely to smoke. And so that picture of the most deprived group, of the youngest and the white mother, those are the mothers who need to be identified so that they can have that support and that information, so that they don't end up saying, I wish I'd known, I wish I could have made a decision, I wish I could have made a difference to my baby's life. The financial impact, so obviously human costs, which I kind of keep going back to, but there are financial costs as well. So the next bit shows that, and this is a bit older now, but 5 years ago, the cost of maternal smoking during pregnancy was estimated by the Royal College of Physicians of over 20 million, which is a staggering figure when you think about it. Within NHS trusts, there are different audits that trusts do themselves, and consistently show that pregnant smokers require more care, and that's obviously more cost. And there are a couple of specific examples here. Barnsley showed that the cost of caring for just 10 women who smoked during pregnancy was over £46,000 compared to £13,500 for 10 non-smoking women. And that's money that obviously could be used in different ways, and time, capacity, staff capacity tied up caring for those women. And then finally, Poole Hospital found that smoking pregnant women cost the trust over £730 extra per patient. And again, that all adds up, and that money could be used in different ways. So in summarising, smoking is the single most modifiable risk factor in pregnancy. This is something we can do something about. It not only causes inequalities, but it exacerbates existing inequalities. And that, again, we can do something about it. So specifically in the North East, annual obstetric costs of managing women who smoke are 2.7 million annually. That is staggering. Healthcare cost savings across the lifetime of each mother and baby unit, £4.8 million. And then last but very much not least, the annual human savings in the North East that could be achieved if that 6% SATOD rate was reached. You can see the number of babies' lives that would be saved, but also the number of babies who would be saved from being preterm or particularly low birth weight. So I just want to end with a comment. A couple of months again, talking to an 18-year-old mother whose baby had died, and having that conversation about, I didn't know that my baby would die. I thought my baby would be smaller. Labour would be quicker and easier. Nobody told me my baby would die. And she just said, I hope other parents will be told. I want things to be better for the next parents. We have a responsibility to identify those parents who need our help and support to understand what the impact is, and need our help and support to make those changes so that they can potentially save their babies' lives. Thank you.
Thank you so much, Claire. We couldn't possibly have asked for a clearer bringing of things into focus as to why we're here and what our goals are. And I've got goosebumps thinking about that 18-year-old who's got the sort of breadth of vision to see that we can make changes to affect other people. So we'll head over to Martin Wilmore, who's the Senior Tobacco Control Programme Manager, talking specifically about the evidence for carbon monoxide monitoring in the pandemic. Thank you, Martin.
Thank you, Ruth, and good morning, everybody. Thanks particularly to Becca and the team for the invite to come and talk to you about slight change of pace now from kind of hard-hitting stuff that Claire's done there on behalf of the challenge group. I'm going to dive into a little bit of the detail here about carbon monoxide monitoring and some of the issues that have arisen over the last 9 months or so, and what the latest position and guidance is from PHE and NHS England, and I guess importantly how we've reached a position of issuing that guidance. It's been, I think it's fair to say, quite a contentious issue. So I'm grateful for the opportunity to kind of talk you through our thinking and the thinking that underpins and the evidence that underpins the position that we're at the moment. Thanks. So wanted to start with a few acknowledgements and a few phrases before we get into the detail. And the first one is to absolutely acknowledge the challenges that the NHS and in particular midwifery and maternity have been through over the last year. I know it's been a really difficult year for a number of reasons, and I know that the profession has kind of felt somewhat beset upon from all sides for many different aspects. And so given that background, I know that some of the challenges about carbon monoxide monitoring might seem relatively trivial, but I think Claire's outlined why this remains such an important issue for everybody, and why we're so persistent in advocating that carbon monoxide is always an important intervention in terms of saving babies' lives and giving mothers the very best chance of having a healthy pregnancy, notwithstanding the unique challenges that we've got this year. It's also fair to say that the pandemic has had a massive impact on the way that stop smoking support has been delivered. We've had over 20 years now of stop smoking services across the country, and the overwhelming model of delivery over all those 20 years has been to see clients face to face and to deliver a program of support in person between a trained stop smoking advisor and a smoker. And very rapidly over the spring and the early summer, those services have had to change to delivering that support overwhelmingly remotely by phone, by Zoom, or whatever means there are. I think it's a testament to the kind of flexibility of the stop smoking services and the way that they've adapted to those challenges, that the vast majority of them have continued to deliver stop smoking support over last year. Ruth was right to flag up, though, that the number of referrals into those services has, I guess, understandably dropped, but they continue to deliver a really high level of quality support to the people that do engage those services. But again, I appreciate it's introduced another layer of complexity in terms of the referral pathway from maternity into stop smoking services, but places have shown that it's not insurmountable. And all of this has been happening over the last 9 months at a point in time when really we were hoping to work with our colleagues in NHS England to be rolling out the smoking commitments within the NHS long-term plan. And there were two key components. One is about supporting all hospital inpatients, but the most relevant one for today, as Ruth explained, was really lifting that model of stop smoking support within the community for pregnant women and embedding that more within maternity services. And the timescales had been that would start in earnest from last spring, and that we'd have a number of pilot sites or early implementer sites that would have been delivering that by now, with one eye on a national rollout starting this April. Clearly, there've been delays to that. The good news is the early implementer sites are now have now received the funding to deliver on their work. I know that a number of them are busy recruiting into posts and hoping to start delivery. I can hear somebody in the background. If anybody could mute themselves. So there's been a delay to delivery of to start of the NHS long-term plan, but that's starting to pick back up now. And the final acknowledgement is just to say that I'm speaking here clearly in my role within Public Health England, but I'm going to use we a lot in terms of the next few slides. And this is the royal we, because we've done a lot of work over the summer with colleagues at NHS England, with those at Infection Prevention and Control, the Health Protection Agency. So the position that we've developed around carbon monoxide is very much a joint position amongst a number of organisations. Next slide, please. So really, I think we need to go back to the beginning in terms of understanding the position that we've reached currently around carbon monoxide monitoring. So back in March, if not slightly earlier, last year in England, the spread of COVID-19 clearly highlighted the need for some national guidance about stop smoking interventions generally. So not just CO monitoring, but as I mentioned before, about face-to-face stop smoking support. I was getting numerous queries and phone calls on a daily basis about whether clients, whether services should continue to see clients face-to-face, whether they should continue to be carbon monoxide monitor them at booking appointments or as part of routine stop smoking care. And it's also true to say at the time that we didn't really know too much about this novel coronavirus or the way that it was transmitted and what the risk was from either from seeing clients face to face, but particularly from a number of clients handling the same CO monitor and what that level of risk might be. So towards the end of March, the government advice came out that all non-essential public health services, so that very much included stop smoking services, should be moving towards a remote model of delivery. So moving away from face-to-face and seeing clients remotely. And I also know that there was guidance issued by NHS England, and I was looking at it this morning from Royal College of Obs and Gynae, also suggesting that non-urgent antenatal appointments could be moved to remote delivery too. And from speaking to colleagues in maternity across the country, I know that was different from place to place and slightly patchy. And I know some places continue to see clients face to face, and others move towards predominantly remote support, and others had a mixture of the two. But essentially, we were in a position where there was no guarantee that pregnant women on clients and stop smoking services were seeing clients face to face. We didn't know at that point about the risks of transmission from CO monitoring, and it was probably the easiest decision in the world at that point to issue guidance from Public Health England, also from NHS England, to say that we should pause CO monitoring at that point. That was, I think that the expression is through an abundance of caution, but it was the only decision that we could make at that point in time. Next slide, please.
Sorry, it's sticking. I am moving it.
Oh, I've broken the slides. I never even touched them. So while we try and sort out the slides, I'll try and remember what the next slide is. But as Ruth has already alluded to, we CO monitoring at antenatal appointments, particularly booking, but also at relevant subsequent appointments, had been recommended by NICE guidance on smoking in pregnancy as early as 2010, and it was fairly standard practice in some places for some time before that. But the NICE guidance 2010 kind of was a bit of a game changer. And then in 2017, that practice was then embedded within the Saving Babies' Lives care bundle. And obviously in the Northeast, through Baby Clear, as Ruth was kind enough to allude to, we'd I think made great strides in trying to embed CO monitoring at every booking appointment, and we'd seen the benefit of that in terms of the number of referrals into stop smoking services going up, but also the number of women being recorded as smoke-free at time of delivery, having fallen more rapidly in the northeast than in the across the country as a whole. So there was lots of good evidence for why CO monitoring as a routine intervention worked. And yet at the same time, we obviously just issued guidance back in the spring saying that we should pause CO monitoring. And one of the conversations at that point was that this had been embedded within Saving Babies' Lives care bundle. If this was something that wasn't going to be feasible for a number of months or even a number of years, then we had to look for an alternative way of routinely capturing biochemically validated smoking status. So we looked at things like cotinine testing, which could be done through urine samples, but all of these really, well, in part took more money to do than CO monitoring, if we're blunt, but also took more time to do and didn't give you the instant result in terms of smoking status that could then inform the immediate conversation between the midwife and the pregnant woman. So whilst there are longer term alternatives, then we were very keen to see what we could do about resuming CO monitoring safely as soon as we possibly could. So that then led into conversations and discussions with colleagues about looking into the feasibility of resuming CO monitoring. I'm gathering that you're still having problems, Becca.
I am. I'm hoping it might work now.
There we go. Thank you. So almost immediately after we'd issued the guidance around pausing CO monitoring back in the spring, we set up a steering group between NHS England, ourselves, the National Lead for Obstetrics, and others within the group to look at the issue of CO monitoring during the COVID-19 pandemic. So the kind of things that we were looking into was assessing the risk of transmitting the virus through use of a CO monitor, and that was really twofold. One was the act of handling a machine, repeated numerous people handling the machine and blowing into the machine. So that's one aspect of it. But the other is just the inherent risk of somebody blowing and exhaling breath into a room with a midwife in front of them. So the two aspects of looking into that. And clearly linked to that was looking also at what filtration standards are built into carbon monoxide monitors. And this is something I'm going to dwell on in more detail over the next couple of slides. Very keen to speak with colleagues in infection prevention and control, which we did quite early on in the process, to understand what their guidance was about carbon monoxide monitoring specifically, but also about whether CO monitoring fell under the guise of an aerosol generating process or a non-aerosol generating process. And again, we'll come on to that shortly. Working with HPA and Medicines and Health Regulatory Authority and other colleagues. And in all of this, one of the considerations was really balancing the risk of resuming CO monitoring against the risk of not resuming it, kind of given what both Ruth and Claire have said about the drop in the number of referrals of smokers into stop smoking services and the well-established risks of continued maternal smoking. So this wasn't a simple decision of a cautionary decision of not resuming CO monitoring without any impacts. It's always risky to talk about stats when you haven't seen the stats yourself, but I was getting a number of trusts getting in touch with me saying that they were concerned about the levels of smoking that they were seeing in pregnancy, and they were also concerned as the year drew on about seeing stillbirth rates start to rise in some of their trusts. Now, obviously, I can't attribute all of that to smoking, but it's just interesting to note that as well as getting a number of queries from places that were concerned about resuming CO monitoring, I was also getting a lot of comments from places that were very eager to resume CO monitoring as well. Next slide, please. So in terms of the viral filtration efficacy, or VFE, which is terminology that I was completely unfamiliar with about 12 months ago, we scouted around to see what evidence there was about how effective the current CO monitors on the market were in filtering out any viruses that may be blown into those monitors. And it's probably important at this point to flag up that there are essentially only two predominant CO monitors on the English market. So one is made by a company, Intermedical, a stroke bed funds, who are their supplier, and the other product is through MD Diagnostics. So two main monitors on the market, both of which have filters built into the CO monitors. So we wanted to understand how those worked and how effective they were. So we were fortunate to find fairly early on that the Health Protection Agency had been commissioned to test those monitors back in around about 2017. And the way that this works, and again, this is stuff that we found out as we went through, is that the Health Protection Agency exposed those monitors to a viral cocktail. So what that means is that they don't use live viruses because that's too risky. But essentially, they create a cocktail of viruses, which includes actually earlier versions of coronavirus, but not COVID-19 specifically, it's fair to say. But this viral cocktail has a size or a diameter of 24 nanometers, and that's relevant because the size of the COVID virus is about 5 times larger than that. So this is a size issue in many ways. That so the results I'm going to give you shortly about the effectiveness of monitors filtering out a virus are based upon a virus that's 5 times smaller than the COVID virus. So what that means is that these are likely to be significant underestimates of how effective the filters are at filtering out the COVID-19 virus, because it's that much bigger and therefore that much easier to catch. And when we get questions about COVID variants and things like that, essentially the key consideration in terms of the filtration efficacy is the size of the particles. And whilst I understand that the shape of the COVID variants may differ slightly, the size of the particles remain largely unchanged. So both of the CO monitors on the English market were tested by the Health Protection Agency, and when using single-use monitors, both achieved over 99.8% viral filtration efficacy against this coliphage, which is the posh name for the viral cocktail. It's also important to flag up that bed fonts have a 30-day replaceable D piece. So for those that aren't all that familiar with the kits, essentially there's 3 components to the bed font products. There's the handheld bit of the kit that has the electronics and the clever bit within it. Then there's a mouthpiece, a disposable mouthpiece that the client blows into. And one of the bed font products has a D piece which connects those two things, the mouthpiece with the piece of kit, and that allows the mouthpieces to be disposable and to be much cheaper. But it is intended to be used for up to 30 days, and the guidance has always been that D piece should be cleaned between users. And when that was tested by Health Protection Agency, and it was tested using a simulation of 30 days of use, it achieved viral filtration efficacy of over 97%. So that highlights to me the importance of cleaning that D piece between each individual user. Surprisingly, there's no definitive standard for what kind of VFE needs to be achieved in order to come onto the UK market. But what was clear from speaking to Bedfont and MD Diagnostics was that all their products achieve all required ISO standards, and they've both done a risk assessment based specifically on COVID and have produced additional guidance in light of the COVID situation. Next slide, please. We also spoke to colleagues at Infection Prevention and Control. They were very clear when they said to us that they defined the process as non-aerosol generating. And because of that, CO monitoring fell into a group of interventions that required a very standard set of precautions. So those included things like a 2-meter distance between staff and clients. It also meant that there was guidance that CO monitoring should be done in a ventilated room. I know there's been questions about what does ventilation constitute. There's very clear guidance from IPC and the World Health Organization about what they mean by ventilation. This isn't PHE using this terminology. This is very much IPC driven. And that there's a standard set of PPE could be used rather than kind of medical grade face masks. And these are requirements that are by and large would be expected to be used when seeing clients face to face. And clearly there's some components to this that are specific to CO monitoring, but equally, if one was to take CO monitoring out of the equation and one were expected to see a client face to face in a room where there was smaller than a 2 meter distance, then clearly there'd be concerns about that too. Next slide, please. So based on the information that we had, we developed guidance over the summer that we submitted to the National COVID Guidance Cell. They reviewed that and approved our guidance, which recommended that as long as trusts could follow the guidance that was set out by IPC about maintaining that safe distance, wearing relevant PPE, having ventilation, and providing that they followed the manufacturer's guidance about cleaning carbon monoxide kits and replacing kits as needed, they could choose to resume CO monitoring. I have to say up front that this remains very much a local decision to be based upon a local risk assessment. But we issued that guidance through the NCSCT for Stop Smoking Services, and NHS England issued similar guidance via Maternity Transformation Bulletin. We work very closely with colleagues to develop some online training guidance via e-learning for health, and that link is on there. And that provides a very brief, maybe 10 minutes module outlining the rationale behind the restarting of CO monitoring and emphasising the infection prevention control considerations that should be put in place before resuming. Next slide. So this is the final slide for me. So just to emphasise really that PHE's role in all this, working with NHS England, is to issue guidance based upon evidence. It's not our role, nor would we ever deign to issue a blanket guidance about resuming CO monitoring. What we have done is issued guidance that lays out the circumstances in which it is safe to resume CO monitoring, but that is subject to local risk assessment. Based upon some of the feedback that we've had, we're very keen to work with the Royal College of Midwives, who are doing some work at the moment about coming up with a national tool to support localities with that risk assessment. And I think it's watch this space. We're keen to work on that quite quickly. We've had a number of queries come in about the new COVID variants, about the rise in number of cases. Whilst I understand that's all of concern, naturally, and that is probably of concern in terms of seeing clients face to face, it doesn't inherently change the guidance about CO monitoring. When we were looking at the safety of resuming CO monitoring, it was based upon the evidence of how effective CO monitors were at filtering out the virus and how effectively we could manage any risks from contamination from being in close contact with clients. It wasn't prefaced upon the number of cases within the community. So that all being said, we continue to monitor the national guidance, the guidance from infection prevention and control, and all this continues to be under review, but we're being regularly asked whether the guidance is due to be changed because of the COVID variants, and the situation hasn't changed. We will be issuing further guidance and further clarity over the coming weeks and months, but for now the position remains the same. Thank you.
Thank you so much, Martin. That's incredibly clear and thorough, and like you say, covering science and terminology that we've never previously had to get our heads around. And just very briefly to put it into context, because we're all in danger of living in our tiny little boxes even more so than ever. You know, the standard PPE guidance that you're describing for midwives seeing a pregnant woman from the community doing a slow blow carbon monoxide reading is exactly the same as what I would have in a cubicle with a COVID positive coughing patient. And you know, you try and keep your 2 meters, but you have just a normal surgical mask and visor, and wash your hands, hand hygiene and distance when you can. And obviously can't do that when I'm attending to them and examining them and helping them up in the bed. But it's kept me safe for a year. So, you know, we're seeing a very unique situation that you're describing, but across the NHS, that's, you know, it's very standard advice and what we're all running with. Thank you so much. And so we'll swiftly move to Louise Hand, specialist midwife for public health from Teesside. Thank you so much for joining us, Louise.
Thank you, and thank you for having me today. So I'm just going to do a very whistle-stop tour of how we re-implemented carbon monoxide monitoring into South Tees. Next slide, please. So we, once the guidance was published, we obviously went through it ourselves within maternity, but we also asked for a trust review. So we took it to our tactical COVID group in the trust just to get some guidance on the trust stance of all things COVID related, and to get some IPC advice as well. The trust seemed quite happy that the guidance was very clear in the conditions that we should be performing this in. So we made the decision to move forward with this because we see it as such a key part in achieving our decline in smoking at time of delivery rates and affecting the smoking rates during pregnancy. So we used a risk assessment in all areas of maternity. We met with all the management team from each area, and we looked at the logistics of monitoring because each area has its own challenges. For example, in shared bays, were we going to do it in there? And in the community setting, we have had a move around in community due to COVID. So lots of GP surgeries are not wanting midwives working out of there. So we have moved to community hubs. So it's about assessing the environment that we were in and trying to make it as reassuring as possible before we started to brief staff and get their views. Next slide, please. So we briefed all of the staff, we gave them time to complete the online risk assessment for their own clinical area and to feedback any views and concerns which were raised and discussed. Obviously, as Martin touched on, rising rates in the community was a big one for staff. So being able to share the evidence, share the briefing with the staff was really, really helpful. And actually, staff are really au fait with the CO monitoring and have always had a good compliance with it, so it was taken to really well. We've always had a management process for monitoring compliance in terms of CO monitoring. Obviously, we submit the data for saving babies' lives, and to ensure that we're 100% compliant, we do a monthly monitoring process, and we have really good buy-in from our community managers, so that if we have persistent midwives who aren't referring appropriately or aren't CO monitoring appropriately, then we can address that and put some support in place, a package, some training perhaps. So the CO part element of that remains paused because we don't think that's fair for the staff at the moment, because we are in uncharted territory really in terms of COVID, but we still continue to monitor the compliance of referrals, and we should hit 100% every single month without fail. And we have a really robust system for supply of monitors and consumables in place. We made sure we stocked up on our consumables for the midwives. We made it really clear about the evidence and low transmission of viruses, how effective they were, and the importance of them replacing the D pieces and cleaning the monitors. One of the staff came up with a great idea of just using permanent markers on the D pieces, for example, just to write a date on, so that we're all really aware of when they need changing and there's no danger of those going over the 30 days. Next slide, please. So it was really interesting to hear what the patients were saying to us. So we run, it's called a STAR clinic in our antenatal clinic, which is an extended intervention for all smokers. So when smokers are identified at booking, when they attend for their 12 and 20-week scans, they're seen in the antenatal clinic, and we provide an extended intervention using a doll, a placenta, a picture of a placenta. We would normally carry out CO monitoring, and we can offer an NRT voucher to take away to a local pharmacy at that point. So it was interesting to hear what patients felt like when we suspended the CO monitoring and then when we re-implemented, and people were shocked that we weren't doing it. There was an expectation that midwives would be doing that, or maternity care assistants would be doing that, following obviously the implementation of the baby clear. But we explained the process to all the patients. Everybody's accepted, nobody's refused to do CO monitoring. The staff in antenatal clinic in particular have been fantastic, and community re-implementing this, following all the guidance. We're very clear about the need for ventilation, and in a couple of our GP surgeries aren't well ventilated, there's no window in the room, and they simply don't perform the CO monitoring at this time. Again, feedback from 1 or 2 of our patients has been that they like the visual reading, it really motivates them, and they are much more accepting of NRT if they can see that number, because then it just promotes even more the discussion around the risk element. And now we've got the regional pathway and the script that goes with it, it just reinforces the importance of that. Next slide, please. So as Martin touched on, obviously our staff came to us and we made sure we had an open door policy to any concerns that they had. You know, we re-implemented this, the guidance came out, and it probably took us a good month to look at this and make some plans, because we didn't just want to rush this out. So as this was happening, obviously the COVID rates locally were rising. We moved up a tier, and then obviously lockdown came around. So it was really important that we looked after our staff and provided lots of reassurance. I think it's been a very difficult time for maternity staff. We've had lots of changes to what we're doing. We've suspended services, we've re-implemented services. We've had partners in, we've had partners out. So it's been a tough time. So it's really important to build people's confidence around the process. The ventilation issues, as I've alluded to, some areas were an issue. We haven't re-implemented, for example, on the postnatal ward in the shared bays, just because of social distancing and because of not wanting to open the windows on there with the babies in the room and temperature problems. But we are doing it in the community, and as I said, we are doing it in the antenatal clinic and making the most of those opportunities. Another one was around mask removal. So some staff, a couple of staff were concerned that we were taking masks off patients. However, it is a very brief down of the mask, and we do that for COVID swabbing. And we COVID swab obviously a lot of patients for elective admissions or spontaneous admissions as well. Partners in room was another concern, or anybody else being in the room. So we're very clear that the staff member moves to the door, the patient goes near the window, they blow, and then you can come back together. All of the briefing, the guidance and everything is put up in every single clinical area and was sent out to all members of staff as well. They all returned an individual risk assessment, and all of our staff have already done the online training around CO monitoring, and it's part of our mandatory training as well that we do BBA and CO monitoring as part of that. The equipment, again, to provide extra reassurance, as I've said already, we contacted the manufacturer, we got clear guidance from them around best practice. It's about being really aware, keeping the equipment clean and reducing any risks, but we're using lots of different equipment, and a CO monitor is no different to anything else. It's cleaned in exactly the same way with our wipes that we know can get rid of any virus. So again, it provided reassurance to staff. Next slide, please. So we re-implemented formal monitoring of smoking referrals. We are back to 100% compliance. I think there is a little bit of when we suspended the CO monitoring, we noticed there was a little bit of a drop in compliance in terms of referrals. I think people maybe sometimes it isn't as at the forefront of people's memories as it would be if we were doing an actual task of CO monitoring. So that's back in place. I'm happy to say we are 100% compliant month on month since we've re-implemented. And again, the process for management review is back in place, which works really, really well. Next slide, please. We also, during COVID, had to make some amendments. So we, in maternity at South Tees, we actually were ahead of the trust in the smoke-free, and we did a smoke-free ward in maternity before the trust went smoke-free, and implemented NRT in all of our inpatient areas in maternity before the trust. So we it's a long-standing thing, and we are very experienced with NRT now. So we've continued to offer that in all inpatient areas. It is on a PGD. But what we did during COVID to try and make things easier was we introduced NRT for partners, and we got that put on a PGD as well, so that all birth partners can have NRT given at the point of admission with their partner to assist staff. Next slide, please. So what are the things we learned? Well, it's really important to provide regular updates for staff, to provide reassurance. You know, I think we couldn't have done this. I certainly couldn't have done it on my own. We have a team of public health champions in each area at South Tees that are really key to driving those messages into their area and providing confidence for staff. Clear messages around the need for ventilation, no woolly messages. This is what you need to do. If this isn't at the acceptable standard, then we don't carry out the procedure. Staff are apprehensive with rising virus rates, but as Martin said, this isn't something that was reintroduced due to low rates. It was something that was reintroduced because of safety. And the smoking intervention clinic remains very effective in an RT uptake. We get very, very few declines following that, and certainly the COs really strengthened that alongside the regional pathway script. Next slide, please. Thank you very much for listening.
Thank you, Louise. That was a whistle-stop tour, but some really clear and practical advice about, recovering services and maintaining them. Really impressive how quickly you can react to the changing circumstances and guidelines, and also sort of how reflective your process is. Seeking reassurance for staff and the pregnant women using the service that's ensured the compliance, and the whole team have been on the journey with you. Really impressive. I'm sure we've all taken a lot from that. I'll quickly pass over to Dr. David Crane, talking about the smoke-free app funded by the ICS. Thank you.
Thanks very much, Ruth. It's a privilege to be here. We're very keen. We think we've got something that can help pregnant smokers, and we're very keen to help if we can. Next slide, please. So essentially what we're a stop smoking app that's available for Android and iPhone devices, and we've got a very wide range of tools within the app, from light touch features, that's progress indicators such as time smoke free, money saved, the health improvements have been made, to more in-depth types of stop smoking programs, and I'll go over those in a bit more detail in a moment. We are, by virtue of being an app, available whenever someone needs and wherever they are. So no need to go to a clinic during opening hours, or to even have a smoking emergency and then need to look for a phone number. Your app is on your phone and it's available as soon as you open your phone. And then we'll provide lots of reasons to encourage people to open their phone as well, like these progress indicators, for example. We're a very science-based organisation. My PhD is in app-delivered behaviour change, which I studied at UCL with Robert West and Susan Mickey and Jamie Brown as my supervisors, and we follow NICE guidance, we implement NCSCT best practice, and we've been proven effective in 2 randomised controlled trials. Thanks, Ruth. One of the main features that we have is our stop smoking plan, which we've called Blitz Your Quit. So this delivers the NCSCT standard treatment program in digital form, with a setup session and then 4 weekly sessions. The setup session customizes the plan to the smoker's needs, make sure it's tailored to them, and then the check-ins help people, the pregnant woman, learn from the previous week and prepare for the next. So always keeping them on track. And outside of this time, there is 24/7 support from stop smoking advisors and a whole range of other tools. But the plan is the thing that allows a pregnant smoker just to have that sense of accountability, to be able to go back to somebody and report not smoking, for that person then to be very celebratory about that. And of course, because all of this is anonymous as well, if the smoker needs to go back to the advisor and say, actually, I'm having difficulty, or maybe I've lapsed, there's less cost, there's less emotional cost to doing that. It's less embarrassing to be able to admit those things to someone who can't see you, who's not going to judge you, or you don't feel is going to judge you. And so we hope that this encourages more openness and more returning to the service, so we can help people get back on track. And then, of course, the other major benefit about an app, and an app like ours that provides 24/7 coverage, is that we can users can check in whenever they want. They're not set to a particular time that they then may not be appropriate for them next week. They can check in whatever time of the day or want is appropriate to them, and then we will encourage them to check in too. And the quote at the bottom says is that from Andy McEwen at the NCSCT, that we are the only app that delivers the NCSCT standard treatment programme. As I mentioned, we also offer 24/7 advice from live trained advisors who normally respond in a couple of minutes. If people say they've smoked in the app, we steer them towards the advisors, or if people are having a smoking emergency, they may come on and want to be talked off the ledge. Also, people may have a question about quitting, which they can come to the advisor and ask us whenever it comes up. So that's why, because it's asynchronous conversations as well, they can have a think about a question, post it, and then go away and do something else, but be notified when they get a response. So you're not hanging on the phone and waiting for a reply. On top of the support that we offer, that's the one-to-one support, there's group support from advisor-led stop smoking clinics that are held 4 times a day on a range of smoking issues, dealing with cravings, recovering from lapse, choosing medications, being around other smokers. And then we have peer support, which is available within the clinics themselves or in our companion Facebook group. And there's about 10,000 people on that Facebook group now. And this peer support is really effective because most people don't get that in their day-to-day life. You can't really go and tell your friend, oh, I'm really struggling right now, I'm really proud of myself right now, because, you know, eventually, or they may not get upset with you, but you may fear that they'll get upset with you, so you may sort of self-censor. But here with these types of groups, that's encouraged, that's what we do. And so that people tell us that they really like those types of peer support that we offer. Next slide, please. Now we get into a bit more detail about some of the programs that we have. There's 2 I'd like to sort of talk about today. One is our missions, and these are short stop smoking tasks that are given daily for the first 30 days and then decreasing frequency up to 100 days. So we've got a 3-month stop smoking program here, and they're designed to help people form a new non-smoking identity, to feel proud about that, to boost their motivation and their self-confidence in quitting, and then to provide rewards as a result of quitting. We have run a randomized controlled trial of this with 28,000 participants, and this found that people who got the missions were twice as likely to be smoke-free at 3 months as people who received the kind of core features of the app, the progress indicators that I was mentioning. And this is important because the missions, which are based on Susan Mickey's identified behavior change techniques, it's not just enough to have those techniques. It's not just enough to say, okay, what we want to do is strengthen ex-smoker identity. How you do that is the critical bit, especially online. Because if you don't do that in a way that people want to respond to, then they quite simply won't use your intervention. And so what I think the missions show is that the form of the plan that we have created is acceptable to users and is effective amongst them. The next slide, please. We've also got evidence that our second automated support system works. This is our chatbot, which follows the standard treatment program again, but digitizes it fully. Here, because we're not burdened by human costs, we can check in with people much more frequently. So we check in twice daily during the first month, again, just to create that sense of accountability, to provide a bit of positive reinforcement when someone has been successful at not smoking, and so we're very celebratory in that way. And then we provide on-demand help and a range of different types of things with a bit of artificial intelligence in there, so we can deliver the right bit of advice to the pregnant smoker at the right time. We've done a trial of this as well, and this has also been found to be effective. This was compared against the missions, so the effectiveness rate of the missions is improved upon by the chatbot, which again just shows that I think we understand how to provide digital support. The next slide, please. And then there are at least 3 and possibly more benefits to both pregnant women and midwives. So one is that the app is enjoyable to use. We hope, and we've got the evidence or the feedback that says that it is. And again, this positive reinforcement, this multiple touch points, a variety of ways for people to get help, allows us to stay in touch with people and form good relationships with them. It provides this convenient and anonymous access to support, and it isn't really burdensome. It's not complicated to use. It doesn't drain the app battery. It doesn't use data particularly. And then for midwives, it basically we can take over any of the stop smoking treatment that happens. So you do a CO monitoring, someone records that they've got CO in their breath, and then you can simply say to that pregnant woman, here, use this app, and then we will take care of everything else. And you can trust us to do that properly because we're evidence-led and best practice, and we're scientifically proven, and we follow NCSCT. And I think what we have in the app is the ability to reach some hard to reach groups, people who might be treatment resistant, the younger smokers who are struggling. And it is an important tool for delivering the long-term plan where we need to come up with new ways of delivering stop smoking behavioural support. I'll just skip through the next slides fairly quickly, just to mention that we've got a very experienced and balanced team that's diverse. You may recognise the name Louise Ross, and we've got also our scientific committee, which is very strong in smoking cessation with Robert and Jamie at UCL, and Olga, who also you may know. And then we are the highest rated app. We've had 5 million downloads in 8 years. We've had 164,000 5-star reviews from usually quite grumpy, recently ex-smokers. And we're the #1 app in the App Store, we're the #1 app in Orca, and we are the #1 most recommended health app of all the apps on Orca, above Headspace, above Wiser, above the NHS apps. Healthcare professionals recommend our app more than any others. And I think if you could do that, if you could recommend our app to the pregnant smokers you see, you'll be helping them quit, and you'll be giving them that sense of confidence that we can help them with this, one of the most difficult challenges they face behaviourally. Thank you very much.
Absolutely incredible, David. Really exciting and like you say, an absolutely valuable extra tool in our armoury, and still more utility to unfold, I think, despite the 5 million downloads already. I'll pass straight over to Dr. Rice-Aquino to feedback on the evaluation on this. Thank you.
Thank you, Ruth. Hi, everyone, and thanks again, Becca, for inviting me to be here, and obviously to Ruth for chairing this really important session on tackling tobacco dependency in pregnancy during COVID-19. So my name is Rice, and I am currently leading the evaluation of the smoke-free app in the North East and North Cumbria. So I'm based at the NIHR Applied Research Collaboration. So today, I'll really be sharing with you some of the development and progress of this evaluation, of this implementation of the smoke-free app for pregnant women and their partners in our region. So firstly, I'd like to acknowledge our colleagues who have helped to get this work off the ground, and that's in no particular order: Joanna Feeney, who was at Fresh when this piece started and is now at PHE, and Becca Scott, of course, at the LMS, who has driven this work forward and led us all superbly throughout this process. Our colleagues at the ICS who have supported the funding and the delivery of this work, David Crane, obviously at Smoke Free and his team, and colleagues at the North of England Commissioning Support Unit who have provided us excellent support, particularly in the development phases of this evaluation. So as Ruth and Clea have described eloquently earlier, there is a national ambition of having 6% or less of pregnant women smoking by the end of 2022. So for our region in particular, this translates to around 2,700 fewer pregnant women smoking each year. The region has a robust maternity pathway for identifying smoking cessation support needs and facilitating referrals for support and treatment, all in line with NICE guidelines. COVID-19, however, has put a spanner in the works, resulting in substantial reduction in antenatal appointments following the first lockdown in April and May 2020. But also due to COVID, however, the implementation of the smoke-free app as an extra support tool has been accelerated. So this was really in recognition of the potential risks of reduced smoking cessation support. For example, when carbon monoxide monitoring was paused. As Martin has already discussed earlier, there was an extensive review of the safety of CO monitoring, and this is now slowly resuming in practice, again in line with current PHE guidance. And Dave has given us a comprehensive summary of what the smoke-free app can do, so I won't repeat that here. But what I'd like to highlight first of all is that the integrated care system has funded 700 9-month licenses for pregnant women and their significant others to use the smoke-free app in our region. So what's really important is that when innovations or interventions like this are implemented in the real world, is that they're also evaluated. So we know that the smoke-free app is effective in the general population, but we're less clear on, oh, sorry, can you just go back to the previous slide? We are also less clear on its impacting the pregnant population. We also have limited knowledge of whether the app is acceptable to healthcare professionals that are responsible for promoting the use of the app, as well as pregnant women and their significant others who are our target users in this instance. So really developing an understanding of how, in which contexts or circumstances and for whom the smoke-free app works is crucial for optimizing its delivery and uptake. Next slide, please. So therefore, we aim to assess the implementation of and engagement with the smoke-free app for pregnant women and postnatal women as well, and partners and significant others in the North East and North Cumbria. Our objectives are to describe the app uptake among our app users, app usage as well, and changes in self-reported smoking status. We also aim to explore user engagement, and that's how people are using the app, and barriers and enablers to engagement. Finally, we look to explore healthcare providers' experiences of implementing the app. Next slide, please. So to do this, we are using a mixed methods approach, which will provide us with in-depth contextual information that will be useful in interpreting the quantitative usage data that's drawn from the smoke-free app. So qualitative data by way of interviews, so this will be by telephone, Zoom or Teams, will be used to explore the similarities and differences between users from different areas and backgrounds, and also allow us to explore any intended or unintended effects. So an example of an unintended effect would be seeking support elsewhere. So for the interviews, we aim to gather a broad range of views. So we're recruiting pregnant women and partners who use the app, and that's done through Dave and team at Smoke Free, as well as those who decline to engage with the app. And we are recruiting these pregnant women and their partners through their referring healthcare professionals. And that's really to better understand the barriers and enablers to uptake of this additional smoking cessation support tool. We're also interviewing healthcare professionals who refer pregnant women and their partners to understand the barriers and enablers to the implementation that they've experienced so far. So we're approaching healthcare professionals through Becca at the LMS. So in terms of analysing and interpreting this data for the app usage and self-reported smoking status data, these will be analysed using descriptive statistics. And then for the interview data, the plan is to undertake a framework analysis to allow us to integrate these various data sources, and at the same time allow us to develop a framework of understanding in line with our evaluation aim and objectives. Next slide, please. So very briefly, our progress to date. Next slide again, please. So as you can see, since the app rollout in June 2020, there's been a slow and steady uptake of the app from various localities as well as deprivation areas. Most of the users have set a quit date, and there have been 63 recorded sessions. So these are activities within the app. So it's worth noting here, however, and do correct me if I'm wrong, Dave, since you're on this call, that 5 of these 18 users so far were test users. So it's been quite a slow progress so far. Nevertheless, we can see a wide geographical spread in terms of uptake. And as you can see from the middle pie chart, there were 9 users that used the app coming from an area with an index of multiple deprivation score of 1, meaning they're coming from the most deprived areas. So from Clear's talk earlier, we know that these are the groups that are most likely to be smokers at booking, and they are the ones that require the most support and information on stopping smoking. Next slide, please. So following ethical approval for this piece of work, we were able to start recruiting for interviews at the end of November last year, approaching both pregnant women and their partners and healthcare professionals. So it's really important to explore these barrier enablers to uptake and delivery, so that we're able to make the changes to help mothers and their partners to use this tool to support them to quit smoking. So in terms of the parent group, all of the registered accounts on Smoke Free had been invited, and a further 3 were invited via their referring midwife. Unfortunately, no one has been interviewed since, so it's been an uphill battle to kind of engage with these pregnant women, but we're continuing on. Concerning the healthcare provider group, however, we have managed to approach 2 areas to participate in interviews and managed to interview 1 midwife to date. So a very, very early insight from this interview is the challenge of raising stopping smoking with pregnant women and their partners in the absence of carbon monoxide monitoring, as well as the limited ability to share kind of any tangible materials, for example, like flyers and so on, to minimize the risk of COVID-19 transmission. So concerning the CO monitoring, though, the hope is that obviously as it slowly resumes, as Louise has illustrated in her talk earlier, that the conversation around smoking cessation will be much easier to broach. So on the whole, so far, the rollout of the Smoke-Free app and the progress with the evaluation has been slower than what we had expected. But of course, there were various reasons for this, not least of which some challenging workloads, competing priorities, and ever-changing protocols and guidance following this public health crisis. Next slide, please. So that being said, I'm really eager to progress this important work this year, and I'd be really grateful if you're able to promote this evaluation alongside the Smoke-Free app for your teams and colleagues. So participation in interviews, as I mentioned earlier, is over telephone or Zoom or Teams and lasts no more than an hour. So pregnant women and their partners who participate in these interviews as well will receive a £15 voucher for their time. In the meantime, we will continue monitoring the Smoke-Free dashboard usage data, and also continue sharing information on the evaluation as much as possible. And as a final note, I'd like to emphasize the important point that my colleagues have shared throughout this session, and that's we need to continue to do all that we can to help reduce the risk of devastating maternal and child health outcomes for mothers and their families through providing them support to make these changes to help them stop smoking. Thanks so much for your time.
Thank you, Reese. Incredible, very fast paced. I'm furiously taking notes as you're speaking, and I'm sure everybody will have learnt from that. I think there haven't been many questions raised in the chat, and I think that's a reflection of absolutely how comprehensive and thorough the talks have been, and I'm extremely grateful to the speakers for their time and enthusiasm and expertise. My take-home messages are certainly that we must act quickly to regain the ground that we've lost because of COVID, and I'm absolutely blown away by the way that colleagues have found to do this, despite the environmental challenges, that it is safe for us, if it is safe for us to see patients and mums face to face with standard IPC guidance for COVID being met, then it is safe for us to get back on with carbon monoxide monitoring, and everybody has reminded us how this is an absolutely crucial and powerful tool to identifying the smoking mums and helping them engage in a quit attempt. It's so visible and tangible and starts the right conversation. That there's some really exciting opportunities to get up and running and regaining speed with the long-term plan and its rollout, and tremendously exciting options being offered by the Smoke-Free app, which we really need to push and make available to all. It will certainly touch some mums that we would otherwise struggle to get to, and be tremendously acceptable in the way it's used, how accessible it is, particularly heightened in the sort of pandemic situation. Thanks enormously as well to Becca Scott for pulling this all together and inviting the tremendous panel of speakers. And there's a furore of all the resources being put in the chat box, so hopefully everybody's able to access that. So if there's no further comments or questions, I'll draw us to a close. Thank you.